Hi everyone. Today we're going to talk about statins. I know, boring, right? Most clinicians listening already know quite a bit about statins. You already know they reduce cardiovascular events and remain first line therapy for lipid management. But today we're going to explore parts of statin therapy we rarely talk about, the nuances that I believe can genuinely change how we practice medicine. In this episode, we are going to explore three key concepts. 1. Pleiotropic effects of statins beyond LDL-C lowering. 2. Choosing the right statin in special populations. 3. Why statins remain foundational therapy even in the era of newer lipid-lowering drugs. Statin intolerance deserves its own deep dive, so we'll tackle it in the next episode. Welcome to Lipid Curious, an educational platform focused on simplifying lipid management for clinicians. I'm your host, Dr. Vishnupriya Pulipati, a board-certified endocrinologist and lipidologist. If you haven't already, you can explore the complimentary Lipid Curious Starter Kit at lipidcurious.com, a practical educational resource covering several key lipid concepts. A quick reminder, this content is for educational purposes only and not medical advice. All right, let's get started. Statins are often described as lipid-lowering drugs, which is true. They are very effective at reducing LDL cholesterol. But their benefits extend far beyond LDL reduction. These additional actions are known as pleiotropic effects of statins. In a way, statins are better thought of as anti-atherosclerotic therapies, not just cholesterol-lowering medications. At molecular level, statins inhibit HMG-CoA reductase, the rate-limiting enzyme in cholesterol synthesis. When the hepatic cholesterol production falls because of this inhibition, the liver increases its LDL receptors, pulling more LDL and VLDL remnants from the circulation for its own metabolic needs. But this pathway of cholesterol production also produces important signaling molecules called isoprenoids, which influence inflammation, oxidative stress, endothelial function, and vascular smooth muscle activity. By altering these pathways, statins exert several beneficial effects beyond LDL-C lowering. They reduce the ApoB containing lipoproteins by taking away from the circulation. This lowers the number of particles entering the arterial wall. They improve the endothelial function, helping the blood vessels maintain normal vascular tone. Statins also reduce inflammation and oxidative stress within the vessel wall. And perhaps more importantly, they stabilize the atherosclerotic plaques by reducing the lipid core and strengthening the fibrous cap, making these plaques less likely to rupture. Overall, statins exert multiple beneficial effects, including anti-inflammatory, antioxidant, antithrombotic, and plaque-stabilizing effects in addition to the cholesterol-lowering impact. Statins have also been studied for potential roles in areas such as immunomodulation, neurological diseases, cancer biology, bone metabolism, and kidney disease, though the clinical significance of these findings remain unclear. Taken this together, these effects explain why statins provide such a powerful cardiovascular protection. They reduce LDL-C by 20 to 60%, reduce triglycerides by 10 to 30%, increase HDL-C by 5 to 10%, and decrease inflammatory hsCRP by 13 to 50%. Understanding these broad effects help explain why statins remain such a powerful therapy today. But in clinical practice, another common challenge is choosing the right statin for the right patient. There are 7 statins available in the United States, but in practice, 3 cover most complex clinical situations. Okay, this is going to make your life way easier. Atorvastatin, rosuvastatin, pravastatin. While statins share the same mechanism, they differ in potency, metabolism, and drug interactions. A few quick pearls about statins. You don't need to remember every one of them, but I think it gives you an overall view about statins and mild differences between them. Atorvastatin 40 to 80 milligram and rosuvastatin 20 to 40 milligram are high-intensity statins. The way I remember, atorvastatin A looks like a 4, so atorvastatin is 40 to 80 milligram. Rosuvastatin R, a part of it looks like a 2, so 20 to 40 milligram are considered high-intensity statin. Rosuvastatin is slightly more potent, and both these statins lower triglycerides in a dose-dependent manner. Simvastatin 80 milligram technically qualifies as a high-intensity statin, but it is not recommended. Doses above 40 milligram of simvastatin are generally avoided due to higher risk of muscle toxicity and rhabdomyolysis. Pravastatin, pitavastatin, and fluvastatin generally have fewer drug interactions and lower muscle toxicity. Rosuvastatin should be started at the lowest dose possible in patients of Asian ethnicity due to its pharmacokinetic differences. Now, since cholesterol synthesis peaks at night, short half-life statins like simvastatin are best taken in the evening, while longer half-life statins such as atorvastatin can be taken any time in the day. Lovastatin should be taken with meals to improve absorption. So today I wanted to reflect on some of the common situations I encounter in clinic and how I navigate the statin choices. If someone has ASCVD or diabetes mellitus, then we typically go for high-intensity statins. Those would be atorvastatin or rosuvastatin. In patients with heart failure with reduced EF due to ischemic heart disease and at least 3 to 5 years life expectancy, moderate intensity statins such as rosuvastatin 10 milligram may be considered. Now let's talk about individuals with pre-existing chronic kidney disease. Statins are safe in non-dialysis chronic kidney disease. Atorvastatin and fluvastatin require no dose adjustment in severe renal impairment. These statins undergo minimal renal clearance, so dose adjustments is usually unnecessary. Other statins may require dose reduction, especially when the creatinine clearance falls below 30 ml per minute. If you are forced to choose a statin beyond atorvastatin and fluvastatin for a patient with kidney disease, renally dosed pravastatin may be safer. Statins are generally not initiated in dialysis patients, but therapy can be continued if they're already on it and may be considered in those with very high LDL-C levels, such as more than 145 milligram per deciliter. Next up, handling patients with pre-existing chronic liver diseases. Statins are safe in stable chronic liver disease, including metabolic dysfunction-associated steatotic liver disease, which is MASLD. They are contraindicated in decompensated cirrhosis or acute liver failure. Pravastatin or rosuvastatin are often preferred, and starting at lower dose with constant monitoring is recommended. How about patients with pre-existing myopathies? Statins are generally avoided in certain inherited muscle disorders, such as Mecardle's disease, due to the risk of rhabdomyolysis, and statins already have some effects on muscles, as we all know. Among the statins, pravastatin, fluvastatin, pitavastatin have lower intrinsic muscle toxicity if we have to choose a statin in patients with a tendency to have muscle issues. Next up, patients with HIV. For patients receiving antiretroviral therapy, pitavastatin is often preferred due to minimal drug interaction. The way I remember, HIV, PI, pitiva, so the I comes second. Atorvastatin, rosuvastatin, pravastatin are reasonable alternatives at lower doses. Simvastatin and lovastatin should be avoided in patients receiving protease inhibitors or cobicistat. Next up, inflammatory conditions. We have patients with rheumatoid arthritis or inflammatory bowel disease or other health conditions. Atorvastatin and rosuvastatin are particularly effective at reducing inflammation. Rosuvastatin is generally considered one of the best statins to use with colchicine. Other safer alternatives with lower interaction potential would be pitavastatin, pravastatin, and fluvastatin. solid organ transplant, such as patients with renal or hepatic transplant. Dyslipidemia is very common after solid organ transplantation because they already have an high cardiovascular risk and immunosuppressive therapy makes it worse. We can consider starting low-dose pravastatin, fluvastatin, atorvastatin, rosuvastatin, simvastatin, and adjust as tolerated with careful monitoring. If they are not on cyclosporine, we can even titrate these statins up to moderate intensity level. Last, pregnancy and lactation. Statins are generally discontinued during pregnancy and breastfeeding. Ideally, statins should be stopped 6 to 12 weeks before planned conception. I usually have a tendency to stop it 3 months before a patient is planning for pregnancy. Statins may be considered only in very high-risk patients such as homozygous FH or established recurrent ASCVD after careful risk-benefit discussion with the patient. Among the statins, pravastatin is the most frequently studied in pregnancy. Why statins still matter in the era of new lipid therapies? We now have powerful therapies such as PCSK9 inhibitors, inclisiran, bempedoic acid, and several emerging agents. So the natural question arises, are we still stuck in the past with the statin? Do they even matter today? The short answer is absolutely. Statins remain the foundation of lipid-lowering therapy for several important reasons. First, evidence. Statins have one of the most robust evidence bases in cardiovascular medicine, supported by decades of randomized clinical trials involving hundreds of thousands of patients. They consistently reduce myocardial infarction, stroke, and cardiovascular mortality. Second, effectiveness. High-intensity statin can reduce LDL-C by 50 to 60%, and many patients achieve guideline-recommended LDL-C levels with statins alone. 3. Pleiotropic benefits. Beyond LDL-C lowering, as we discussed, statins improve endothelial function, reduce vascular inflammation, stabilize atherosclerotic plaque, the effects that contribute to their cardiovascular protection. 4. Accessibility and cost. Most statins are now generic, inexpensive, and widely available, making them one of the most cost-effective therapies in modern preventive medicine. Finally, statins work beautifully in combination with other lipid-lowering therapies. Adding ezetimibe reduces LDL-C by an additional 25%. Adding bempedoic acid reduces LDL-C by another 20%. And PCSK9 inhibitors, in addition to statin, decrease the LDL-C by an additional 50 to 65%. So while newer lipid-lowering agents are valuable additions to our toolbox, they are typically add on top of statins, not used instead of them. So here are my take-home points for you. 1. Statins do more than lowering LDL-C. They stabilize plaque, reduce inflammation, and improve endothelial function. 2. Most special population clinical scenarios can be managed with 3 statins: atorvastatin, rosuvastatin, pravastatin. 3. Even in the era of new lipid drugs, statins remain the foundation of cardiovascular prevention. All right, folks, that's it for today. I know we spoke about a lot of statins, a lot of indications. There is a visual guide attached to this episode, so you can review that. Now, I have a homework for you. I want you to choose 3 special patient circumstances among the things we discussed, and I want you to practice that in your clinic. For example, going forward, if I see a patient with low GFR and I'm considering a statin, I'll think about atorvastatin. If I see a patient with liver dysfunction, I'm considering a statin, I'll think about rosuvastatin. If I have a patient with HIV on retroviral therapy, I'm going to think about pitavastatin. Whenever you see a patient with these conditions, think about these statins and review what are the doses, and then it'll get so much easier for you. Before I sign off, a quick note. This podcast is intended for educational purposes for clinicians and healthcare professionals. It does not provide medical advice, establish a physician-patient relationship, or replace individualized clinical judgment. And I have a special request for you today. If you know of any cardiometabolic or lipidology fellowship programs, please email me. I am working on putting together a resource for clinicians who are interested in pursuing training in this field. Thank you again for tuning into Lipid Curious. If today's episode was helpful, consider sharing it with a colleague or a friend. You can always reach me at hello@lipidcurious.com. Be sure to follow or subscribe so you don't miss what's coming next. Until next time, stay curious and stay confident. Signing off, Dr. Pulipati.